Unit Alive Chair, I'll hand it over to you.
Thank you, Gordon. So welcome everybody to March's governing body meeting. Welcome everybody. We have apologies from Dr. Da Costa, Councillor Roach and Ian Atkinson. We are, however, quorate. Are there any declarations of interest for any specific items on the agenda? Oh, okay. Are there any patient or public questions, Ruth?
No, Chair, we've not received any.
Okay, thank you. We'll move straight on then to the minutes of the last meeting, going through for accuracy, oops, and any items that aren't on the agenda. Page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 and 14. Okay, thank you then, Lindsay. We'll take that as an accurate record. There's an action log next. I think my one at the top was orange. Probably it's a continual process because the appointment and availability of GP appointments is a constantly evolving picture as the demands on general practice change. So that is happening, but will continue to happen. But it has gone out on a number of occasions. The transition approach, Chris, I think that's going through on a monthly basis. Medicines management reports. Actually, Stuart Lakin is actually here later on, so we'll, as Dr. Da Costa isn't, we'll just have to ask Stuart whether he has updated Dr. Da Costa. For GBAF risk, I can't honestly remember if we've addressed that. Ruth, has that been addressed?
Apologies, Chair, I'd have to check and come back to you.
Okay. And then we've completed the transition executive group terms of reference. Okay. In which case, over to you, Chris, then for the Chief Officer's report.
Thanks, and good afternoon, everybody. Got a few things to go through. Thanks for the waves. So I've got a few things to go through. I've got a few sort of business items just to bring to the attention of the governing body. So I'll just go through them methodically. So the first one is procurement of Rotherham Safe Space. So this is a service that will provide a non-medical model of peer support for those who are experiencing emotional distress and deliver low-level psychological interventions. The invitation for providers to quote was in November, and the outcome of our evaluation will be subject to a standstill period, but it's hoped that will be awarded in January 2022 for a February start date. Again, we'll just have to confirm that when it's all been formally done. With it, obviously, we're just moving into March now, so that should be done, but we'll confirm it formally at in our next governing body meeting. But just to update governing body on the process for that. Similarly, a stroke support service and community integration service. We want to provide it for a further year from 1st of April 2022. This is the service that supports stroke survivors and their families and carers to make lifestyle adjustments they need to make as a result of experiencing a stroke, and hopefully to enhance the quality of life. It's linked, the community integration service is provided by somebody called Live Exclusive. The service supports people on the neurological pathway to wider packages of support, and a key worker provides personalised packages including support, advice and guidance. So hopefully that service again will be run for a further year now from 1st of April 2022. So again, just so governing body are aware of the process and for transparency, just that's what we intend to do. Any questions on those two before I move on to Better Care Fund? This seems pretty straightforward. Okay, so on the Better Care Fund, every year we have our Better Care Fund, which is our pool budget with Rotherham Council. And this is where we work closely together to try and come up with joined up services to make sure Rotherham patients get the best deal possible. It goes through a process and we've been classified as approved, and our Better Care Fund plan now meets all the necessary requirements required by the national team. So we have a formal endorsement of that, and that's attached for people to view if they would wish. The next item is the Rotherham Equipment and Wheelchair Service. We call it REWS. It's delivered the service for many years. It's a 7-day delivery pilot extension. So just things like equipment delays can be sometimes delayed discharges from hospital and slow up the rest of the service. So by having this 7 days a week, hopefully should make everything, patients should have a better experience, and obviously clinical pathways should be a lot more efficient in terms of it being more timely. So a short trial of the 7-day service has been completed, and it's been agreed that the trial will be extended for a further 12 months, and we'll continue to collect data just to reassure ourselves that both clinical pathways are more efficient and patients have the best possible experience. Okay, the next one is the voluntary and community sector mental health offer development. So we recognise that the voluntary and community sector during the pandemics, obviously it's under significant pressure. We're asking more of the voluntary sector. Their ways of getting income have been restricted due to the pandemic. So we've been desperately working together to try and strengthen the sector as much as we possibly can. The proposal is to strengthen and enhance the voluntary sector services mental health provision through the development of a voluntary sector mental health provider network and the provision of specific grants to organisations who are able to support discharge from hospital. So these two developments will complement and contribute to the implementation of the community mental health crisis, suicide prevention, and inequalities transformation work. So again, that's something we've managed to use money which we've had available this year to really bolster up an important part of our health and care system. Linking to that, we have mental health social prescribing. So again, this is mental health social prescribing is something in Rotherham. We were the first area to pilot it. I think, Janet, we had national recognition, didn't we, on the pilot for this? This is trying to think innovatively about how the voluntary sector can help people with looking at the whole person with mental health, physical issues, and trying to come up with a different way of looking at things. So this is just to update on next steps. And we're setting up the mental health scheme and the introduction of the government by the primary care network link workers. So we've had an inequity of access due to the referral routes. So we've now opened it up to any referral from a GP or from secondary care, so they'll be able to access the full social prescribing scheme rather than just a limited amount. So that's good news, and we'll continue to evaluate that, because obviously the evaluation is absolutely key to all of this. So when we come in the future to ask for further investment, hopefully we can show the real difference in terms of efficiency and in terms of the difference to patients that's made to their quality of life as well when we come back as part of the evaluation. Another thing we've done this year in recognition of the unusual situation with the pandemic, we've done some grants to Voluntary Action Rotherham and Rotherham Hospice. This is to support the hospice sector and the voluntary sector in Rotherham, who are obviously a key part of delivering our services. It's a total of 1.75 million. Voluntary Action Rotherham will get $750,000 and the hospice 1 million, and it supports a whole range of issues detailed in the grants. We have shared the detail of the grants separately, but if people wish to see the detail, I'm more than happy to share that again. It's aimed at increasing organisational resilience and sustaining or enhancing service provision to make sure that the Rotherham system is absolutely future-proofed going into the next period as we move into the next stage of the pandemic, which is a bit more business as usual. So I've raced through a bit, Chair, I recognise. Obviously, if anyone's got any questions, do feel free to ask them. I won't go through the communications update. If people can just go through that and take it for information.
Thanks, Chris. It's just a lot of good news about us reinforcing services that really provide benefit to our Rotherham population. Are there any questions? Okay. In which case, thanks. We'll move on. It's still you, Chris. It's mostly you today, Chris. Hopefully you've got a glass of water to keep your voice going strong.
I haven't, but I'll manage, Chair. So just moving on. So my papers are just updating. So we're on to the integrated care system update. So in terms of the South Yorkshire, so just for stating the obvious, so we're currently operating within the South Yorkshire and Bassetlaw integrated care system. The draft legislation, which is just going through Parliament, is just coming to the committee stage, I believe. The intention is for us from the 1st of July to transition from 4 South Yorkshire clinical commissioning groups into 1 South Yorkshire integrated care board. We're still working to the 1st of July date. Obviously, that's not been finally signed off. And as part of that, designate appointments have been made to the executive team, and there were some announcements last week which have been circulated to governing bodies separately around appointments to the executive team. The next step is to appoint the remaining place directors, and they're scheduled for interviews last week in April. And so an exec team will be operating. So the ambition was to have like a shadow board operating from the 1st of April. Probably in practice, that's probably more likely to be May, but there's an ambition to have some sort of shadow running from 1st of April from April to June period. So then ready to go live 1st of July. Still got quite a lot of work to do in terms of transition and human resources for our staff. Our staff do have a guarantee of employment, but HR structures are still being worked through. So there's still a level of uncertainty from that perspective. So that's an absolute priority for us to try and land that as quickly as possible. In terms of design, the finance work stream, which Wendy represents us on, is really doing some sterling work, making sure that we're absolutely in a ready position to transition all our financial arrangements to a new integrated care board. Sue's leading on the quality agenda with the other chief nurses to make sure all our quality arrangements, safeguarding arrangements, and everything that comes under that banner moves safely and securely. All the governance surrounding moving, changing organisations, Ruth's leading on us, and there's a long list of things to work through, Ruth, but I think we're happy with progress to date. And what we'll do is we'll continue to assure governing body through our development sessions. And John, I think formally through audit committee as well, is our formal place where we need to have full assurance. But as I'm reporting to governing body today that satisfactory progress is being made to get to the 1st of July date. But John and the audit committee will be the final judge of that in terms of external assurance or non-executive assurance. So I don't know, John, if there's anything you want to say about progress on that. You're on mute, John.
You're on mute, John.
Sorry. Yeah, Chris, I think the audit committee are having an oversight of that at the moment. We're receiving reports on the progress on transition, and we've also seen the ICS report on that. And it looks like there'll be an internal audit review in the first quarter of the new financial year, covering the whole of South Yorkshire in terms of the transition period. And I think the timescale is emerging now that audit committees have to sign off the transition period near the end of May, because Chris, as Chief Officer, will also have to sign the process off at that stage as well.
Yeah, thanks, John. And it has been quite a fluid situation, hasn't it? It's because we sort of lost a couple of months because of the Omicron wave and us being in a command and control environment, but then we gained 3 months because we moved from 1st of April to 1st of July. Yeah. So we've all got to be on our toes to make sure that we can cope with whatever's thrown at us. But I think from my perspective, good progress is being made, but there's obviously, we've just got to make sure we're absolutely fit and ready to transition between organisations.
Okay, Jeff.
Yeah, thanks, Chris. And we spoke at members committee. I think the delay is sort of obviously out of everyone's hands, isn't it? But in one sense, I think the anxieties at first about sort of ICS is, well, what organisation was that? How would it work? Staffing, but it seems as though it's sort of almost sort of more of the same, that sort of staff have got a stability. We are working towards that transition. We sort of a better idea of sort of who we're dealing with and what we're doing, and it's not like a massive groundswell sort of change that's going to occur on that date, and that potentially gives us a little bit more time to plan and prepare and sort of work through, which isn't necessarily a bad thing. Richard, he did suggest at members committee that, and I know you've sort of said, nothing's sort of really in stone and not tied to anything, but it was suggested that might get pushed back till sort of September. So I'd not hold you to anything, but is that like 1%? It might be September, 10%, sort of 50%. I appreciate you don't necessarily know, but it's just, again, from governing body sort of point of view, what sort of the consideration might be with that.
So can I respond to that, Chair? So basically, the current assumption is that it was 1st of April, but then we were formally told to plan for the 1st of July. And the draft bill there was over 300 amendments proposed by the Lords. That's still going through. Obviously, things will be debated through, but the expectation, if things go as planned, would be a realistic ambition for the bill to go through will be end of March, which would allow a smooth transition for 1st of July. If there were any delays to that bill, then NHS England had contingency plans of a delay of 3 months and 6 months, which went to the NHS England board. So the backstop, if for any reason the parliamentary process was slower than expected, would be a 1st of October date. But we're currently advised to plan for a 1st of July date.
Yeah, thanks.
Any other questions on that? Or should we just move straight on to the next bit of the transition thing, which is the joint CCG changes being proposed, which I think is you again, Chris. You put yourself on mute, but...
Sorry, my computer's just decided to lock up, Richard.
So, yeah,
Just give me a second. Here we are, we're back. So in terms of the Joint Committee of Clinical Commissioning Groups, Richard, you were present last week, weren't you? And I think the key thing is the recognition in the April to June section. We do need to start working as a system. So in terms of, we agreed in principle as a governing body that we would have anything to do with, basically in lay terms, would be anything to do with planning looking forward after the 1st of July would be something that we do as a joint committee with the designate appointments to the Integrated Care Board sitting with us as they're appointed. And us as a governing body would make sure that we absolutely made sure the day-to-day business and day-to-day assurance was kept through the governing body. So Richard, that was, I believe, approved by the joint committee last week. So all 4 CCGs are happy with that arrangement. And that's how we'll conduct our business from the April to June period.
Yeah, so just for the public board to then, the board to just ratify that, say they're happy with it. I'm looking at our governance leading John, that he's had a read and you're happy with how that's progressing.
So if we can record that we ratify that approach, that would be very helpful. And then myself and Richard, as your representatives on the joint committee, will make sure that the appropriate business goes to the appropriate meetings.
Okay, I see everyone nodding. Okay, that's great, thanks. Okay, you can have a short break then, Chris. So move on to performance reports. So finance and contracting, Wendy.
Thanks, Chair. So, hello everyone. Today we're looking at month 10 position. So if I can take you to the top of the report and start as usual with cash and payments, where I'm really pleased to report an ongoing strong performance in both those areas still, with 100% compliance against the national payment targets. That's thanks to Matt and our wonderful financial services team. So moving on to the operational performance and the table at section 5. And just a quick recap on the last 2-month period, because as at month 8, we reported a balanced bottom line but we signalled the likelihood of a surplus position arising in future months, which we were saying was driven by performance in 3 main areas. So there was acute independent sector activity in prescribing and demand for mental health out of area placements. And in confidential session, we shared an assessment of the month 9 position and the fact that we were reporting a 3 million surplus as at month 9 forecast outturn. So at month 10, those 3 areas that we highlighted of significant variance, they've remained and in line with what we previously felt would be the case. And so for which reason we're still holding the forecast outturn at that 3 million surplus. And basically that's it for me. There's nothing I can see is happening within that position that I feel I need to draw your attention to. So I am just going to pause there if that's okay, but as ever, happy to take any questions.
Okay, questions or comments for Wendy on that? All right, everyone is happy with what you say, Wendy.
Thanks, Al. Thank you.
Okay, so we'll move on to the delivery dashboard. So Ian's not here. So
Yeah, I'll take this, Chair, if that's
Chris
okay.
Chris has promised to be able to take this.
Yeah, so I'm the reserve for this paper. So if anyone's got any detailed questions, I may take the option to take it away and come back to you if I don't know the answer. So please bear with me. Rather than go through the whole report, what I'd like to do is focus on the start of the report, and particularly on the performance in secondary care. This is something nationally has become a real priority. We call it the elective backlog. But what it really means is the people waiting for hospital treatment. So this is politically now becoming absolutely number 1. So I'm just going to give a quick summary of where we stand and how we compare to the rest of the country. So in terms of diagnostics, currently Rotherham's performing 16th best out of 106 in the country. We've got 15% of patients not getting it within the 6 weeks target, and against the national non-compliance rate of 29%. So we're not meeting the target, but we compare favourably to other areas. That's a recurring theme in this report. So in terms of RTT, that's a short split referral to treatment. That's the 18-week target. And that's referral from your GP to having a diagnostic to having an operation. The national target's 92%, obviously because of the pandemic, and nobody in the country is achieving that, but we're currently getting 79% of patients through in 18 weeks in Rotherham, and that makes us 3rd best in the country out of 106. So the national average is 63%. So in terms of 18-week wait, we aren't making the target, but we're comparing very favourably to other areas. So as we start to plan our recovery should be a quicker recovery than other areas of the country. Obviously, one of the absolutely key areas that we've been focusing on is the cancer waits. So in terms of cancer 2-week wait, incredibly that we are actually achieving the 93% 2-week wait target, which is incredible, quite frankly. That puts us 11th in the country out of 100 and a national average of 78%. So that's the key. The challenge for that will be maintaining it. The 2-week wait for breast is at 80% against the national target of 93. Again, we're 16th out of 100 in the country against the national average of 50%. So other areas have really struggled with these cancer weight targets through the pandemic, and as we're failing the target again, our recovery we'll see it's, although significant, will be less. The cancer 31 and 62, a similar sort of picture. On 31 day, we're meeting with 97% of patients achieving the timescales. So I just wanted to flag those up. So obviously in terms of South Yorkshire, the new language, we used to talk about 18-week waiters. I remember when I started in Rotherham many years ago, we used to talk about anyone waiting over a year. We've now got patients nationally who are waiting over 2 years. So there's a big drive to really address those quickly. Fortunately, in Rotherham, we don't have any patients waiting over 2 years. And the other key target, I think it's 91 weeks as well, which is another key target. Again, we don't have any patients over that. But within South Yorkshire, there are patients in Doncaster and Sheffield who fit into that category. So it's it's just try and give a picture to governing body that our performance, although we're not meeting many of our targets, we are performing very strongly compared to other areas, and we need to absolutely nail the recovery going forward. So I'll just stop there, Chair, and just if anyone's got any questions on that or the rest of the report, please feel free to ask.
Okay, thanks, Chris. Jeff?
Yeah, thanks, Chris. Yeah, I agree as far as like performance. Even though you're like not hitting target, when you look at sort of what everyone else is doing, that's really quite impressive. And trying to sort of think back where we might have been sort of a year ago, there were a number of things we're still sort of outliers with. I'm just mindful as we sort of move to ICS. I know that's like got place, isn't it? An ICS. Would figures like this we be sort of looked at purely sort of as a place sort of in future, or will we be looking at sort of ICS? And if we are looking at ICS, where do the other CCGs sit sort of in that? Do they actually help us or run along par, or potentially other sort of areas that might drag sort of that down if there's an ICS sort of dashboard that looks at that?
Okay, I'll have a go at answering that, Chair, but some of it might be just personal reflection. So I think as we move to a South Yorkshire Integrated Care Board, naturally equity of access across South Yorkshire should be an absolute ambition for us. So I think that's exactly what we should be looking to do. So whereas we need to look at place to understand what's happening, our ambition should be for all South Yorkshire to be meeting all the targets every time. And I think by the hospitals working together across South Yorkshire, you know, if Rotherham's struggling in one a specialty area, perhaps if we can benefit from getting capacity from other areas, we can share better between the areas as well on a South Yorkshire footprint. In terms of the really long waiters, there's a handful in Doncaster, and I think there's about 55 in Sheffield waiting over 2 years. And they tend to be restricted to the complex orthopaedic pathway. So it's a very specialist area where that issue is. So we can focus in as a South Yorkshire community to try and tackle that area. So it's a very limited area. It's compared to the rest of the ICSs in the north, South Yorkshire is the one that's best performing. It's probably the best answer I can give you. However, that doesn't mean it's meeting all its target. We've still got a huge challenge in terms of elective backlog because of the pandemic.
Yeah, it's useful to know. I mean, I think potentially what you partly saying, isn't it? The focus for where you put things sort of depends on where within the ICS different areas sit. But that might, if Rotherham was poorly sort of down in a particular area, that would help that the ICS might sort of overfund it. Yeah, okay.
Okay, Jason.
Yeah, just regarding the cancer performance, they're still working really hard with the trust to try and make sure that they're doing as much as they can to try and prevent cancer breaches. I have regular meetings with the cancer lead, Vicky Athay, Dr. Vicky Athay, and Jackie Tuffle and I sit on the cancer board at the trust. You know, behind the scenes, there's plenty of work going on there, and you know, recognition that although we might be doing okay, we're not meeting the target, so we're just trying to push that where we can. Looking at doing an improved prostate pathway. They've got a new senior doctor in place there, so hopefully we'll have some better news going forward as well. Thanks.
Okay, thanks, Jason. Any other comments or questions for Chris? I've got to think of some challenging questions for Chris because he's stepped in the last minute and has. No,
we're not mean like you, Richard.
I know, it's terrible, Chris. Everyone's being nice to you. Right. On to Sue then for patient safety and quality report.
Thank you, Chair. Good afternoon. So all the usual areas are covered in the report. I'll just go through. You see the infection prevention and control section, including the C. diff figures. Up to where are we now? To the end of January, they're coming in just under plan for the trust, and just over plan. Where are we? Just under plan for the CCG as well. Reports on the E. coli and work around all the investigations into outbreaks. and root cause analysis there. Support given to across the patch still from our CCG, infection prevention and control nurse. There's a small section there on mortality rates a little bit further in the report. I'm going to come back to that a bit later because Dr. Page is part of the group that is reviewing deaths within the trust, and he's probably got a couple of words to say about that. The numbers of serious incidents, we continue to follow the process and the framework for serious incidents. We were talking about transition earlier. We're having early discussions about how we might manage these, or whether some of them could be managed better on a bigger footprint, but currently still very much working on a place footprint, but ensuring that the learning is directed across the wider footprint. In the safeguarding section, the information that's been shared across the patch, the annual safeguarding update from the CCG, some of the briefings that have been shared with GP practices down there, and the Rotherham Safer Rotherham Partnership Domestic Abuse Strategy, which has been released and implemented, which we are one of the partners to the Safer Rotherham Partnership and are a partner to this domestic abuse strategy. Some of the main points of the strategy are detailed there on page 10. We are looking towards providing a training event for GP practices at one of our PLTC sessions as soon as we can get those back online, and it will cover all the main aspects of safeguarding to ensure that practice staff are compliant with their mandatory training requirements, but we will cover the domestic abuse and the domestic abuse strategy as part of that. It seems very timely in terms of covering that off. And I think they were the only things I was going to mention myself. Just before I take questions, I would just come back to Dr. Page about mortality and the work that the Trust are undertaking in order to review all mortality.
Yeah, thanks, Sue. So, I mean, I've been on a working group for around 9 months now, where we've been meeting regularly and been looking at ways to reduce the mortality in the Trust. The Trust was noted to have higher than expected mortality. And so there's been a really strong working party put together to try and look at that, fundamentally to look at the pathways where people were found to have a higher than expected mortality within the Trust. And they've gone through, reviewing tens and possibly up to hundreds of cases to see where there's been issues and to see where the pathways aren't perhaps being followed to national standards and where things can be improved. I'm really pleased to say that, the mortality now is back down to the as expected category when you take into account COVID. They've also had a look at quite a lot of the coding. So it's a bit of a technical thing, this, but if your patients aren't coded as being as ill as with the past medical history that they have, if that's not coded correctly, then whether you're expected to die from an illness is not correct. So they've done a lot of work on the coding as well there to try and make sure that's accurate. So, it's really pleased to see that there's improvement there, both from the pathway point of view and then at the correct coding point of view to make sure that Rotherham, is now showing as expected grouping rather than the above expected that they're in before. It's been a lot of good work.
Thank you.
Okay, thanks, Sue. Any questions for Sue or Jason? Okay, thanks, Sue. Should we move on to patients?
Yes, thank you. I would just add that I think it's really positive that the CCG so strongly engaged in that mortality review work. I think that's as it should be. We need to be very much engaged with any work reviewing such things as mortality. So on to the patient and public engagement and experience report. It remains a challenge. Engaging and measuring and getting feedback on experience. Nonetheless, Helen manages to graft away and input into as many areas as she possibly can. So looking there, some of the text from the executive summary of the the report published in February, the Community Diagnostic Hub's final report, and that's directly lifted from that report on page 3. We've got the friends and family updates, and I think that there is a challenge around collecting friends and family information that continues. We've mentioned it before in terms of positive and negative and not getting the free text on there. However, work continues. It's a must do, and it continues there. There is some towards the end of the report, some feedback from the vaccine volunteers. I know that we've all been raised our thanks to the volunteers supporting the vaccination programme across Rotherham and wider. They've been an integral part to it, and it seemed a good time, didn't it, Debbie, to capture some of the written feedback that some of the volunteers have given. So we have put that in there in the report. Is there anything you want to add to that, Debbie?
Thanks, Sue. Just a couple of things to mention that it's contained in the report. Helen always writes a really good description. But one or two things that we are doing, obviously we're still collaborating, or Helen is working with colleagues across the ICB as to what exactly the communication and engagement strategy is going to be going forward into the ICB. We've also got some fantastic models of good practice down in the South Yorkshire PCN area, where Tony Cowgill's bringing together GPA, chaired by GPs, meetings of local volunteers, community groups and general practice, sort of looking at how we can actually get that together and sort of learn from each other really, and willing to share that across other PCNs. So that's of note. We're about to, I think, look at rolling out something called a carers pack, which is this a potential really for good practice initiative across GP practices to support carers in that difficult role. So there are quite a few big sort of community engagement projects coming down the stream. One thing we never ever lack is people wanting to get involved, and that's really positive going forward. So thank you.
Thanks. And as always, we do share the Health Watch newsletter, and that's appended. We do. They've just to this report.
Although it's not in our remit and it's not in our gift, they've just done some work looking at dental access, haven't they, Sue? But yeah, that we don't cover that as part of the CCG. So,
okay.
Any questions?
Yeah, thanks, Sue. Thanks, Debbie. Any questions there? Okay.
Thank
Thanks,
you.
everybody. Welcome, Stuart, as the next item. Before you start, Stuart, we just have an action point from our previous meeting where Dr. DaCosta was going to get some more information from you about Q1 drug use. Can you just tell us whether you gave that information to Dr. DaCosta? Can you remember?
I haven't given that information directly to Dr. Costa. That's I've got the information though. It was regarding GLP-1s, and it looked like we were actually prescribing less. We're not prescribing less. It's just that there's been a change in the product description. So while it's the same product, it's trending down on the data, but also trending up at the same time as it's just a change in the description. I'll get that. I've got the data. I've just actually got to finish the job, Richard. So I'll get that email to Dr. Costa.
Thank you. So that was the end of Q1 thing. So on to Q2 then. Medicines Management Report, Stuart. Okay,
so you should have got the report in front of you. What I'll do is I'll just go through the highlights and give you time to ask questions. So at the end of Q2, we still have the lowest cost growth in the Yorkshire Humber region at minus 5.9%, and that has actually continued into Q3. If you look at the top of page 2, you can see what the effect of the NCSO issues were having on our performance at the end of the previous financial year. Our cost growth is below that of the national trend, and it took a dive when the NCSO issues resolved. Going forward, if you look at, I've given you there, and I won't go into all the detail, and I know we love detail, but the top 10 drugs that are increasing in cost and the biggest price decreases, there is no surprises there to us. Most of the price decreases are due to the NCSO issues. That's when no cheaper stock is available. That's when a drug is not available at the preferred, at the drug tariff price. And the biggest increases are around DOACs, anticoagulants, diabetes drugs, and switches that we have done. Zapain be an example of that. If we look at the practices, which is the looking at the PCN and the practice performance, only Morthern Road was showing significant cost growth. That's actually rectified itself in Q3. There is significant cost growth at Queen's as well, but that's down to a specific patient issue. So again, there's nothing in the practices that's causing us any undue concern or requires us to have a deeper dive. The prescribing incentive scheme is underway. At the moment, we've got 41% of the targets have been met. It's only Q2, and it's usually common that this figure picks up in Q3 and Q4. We're normally around 70% of targets met by the end of the financial year. At the moment, that's on track. Again, this is the second year that we've set a prescribing incentive scheme that's not linked to any budgetary management or not linked to the practice retaining costs within its allocated prescribing budget. And it looks like going into 2022-23, we won't be setting practice budgets again. We'll wait and see on that. We have managed to deliver a quick programme throughout the year, and we contribute just over £400,000 worth of savings due to medicine management activity up to Q2 of the financial year 21-22. What I'd like to concentrate is on some of the service redesign schemes, which is on the last page of the report. The depression medication reviews, this is quite a challenging programme, but it's up and running and it is working, and we're managing to do it virtually. We're getting quite a good response rate from a good click rate from the texts that are being sent out. We're getting a fairly good response rate from patients who are then engaging with the team to actually talk through and their antidepressants to review dosages and potentially have support in stopping them. The Care Homes in Hydration project, this is also about to kick off. We're working with 4 care homes that we have identified as being the highest ambulance admissions. Training has started in the one care home, and we're trying to link this into medication reviews using the PCN work practice pharmacist workforce as well. It's a multidisciplinary team. It's very well linked into the antimicrobial resistance work stream. They're really interested in this, particularly because we're monitoring UTIs and antibiotic prescribing rates as part of our outcomes. The virtual training package is almost complete and will be completed by the end of next week. The training, the intensive work in the care homes has already started. We've also been encouraged to put in a bid for national funding for this programme. So I had a meeting last week regarding that. The national team were really interested in what our outcome measures, and it were regarding our hydration project. And it looks like the national programme may have outcome measures very similar to our own. Diabetes clinics, we have the dietitians are all in place to run the dietetic diabetes clinics. We've got 3 practice meetings today going on to launch the clinics, and the PALM tool, which identifies poorly controlled, poorly managed diabetic patients. It's been really well received by practices. So you've just come from practice now. We've identified the patients that are most likely going to benefit from the dietitians clinics alongside the newly diagnosed diabetic patients. Also identifying a cohort of patients which need to be reviewed with the diabetes specialist nurses and the dietitians, and patients who need to be reviewed urgently. It's been really well received by practices, and we're populating those clinics now. And in fact, some of those clinics are already ready full, even though we haven't even got around all patients yet. Chronic pain, we're really looking forward to doing something in chronic pain in 22-23. We've got funding again to run a pilot service, and we're putting that back together. I'd really like to talk about infant feeding pathway for a few minutes. It's not a huge pathway, but all infants with feeding problems with suspected cow's milk protein allergy get referred to the dietitians. We've had 87 referrals in the first 2 quarters of the year. Actually equates to 13% of all Rotherham newborns. So 30% of all newborn patients are going through this pathway. 91% of referrals are seen within 7 days, which is brilliant, and only 6% of patients get referred on to a paediatrician. And in fact, the patients who weren't receiving in 7 days, that was a delay on the patient's behalf, not the services. So we've had a massive reduction already. So in January 2021, we had 216 patients diagnosed in the service with cow's milk protein allergy. Now the pathway is completely controlled by the dietitians. We've already seen a 33% reduction. 33% reduction in the number of patients in that pathway. We've not seen a reduction in exponential cow's milk allergy yet, but as long as nobody tells Wendy, that'll be fine. Actually, Q3 figures, we are seeing a reduction in cow's milk protein allergy. There is generally a lag on these things before you get the reduction in costs, and we are seeing that already in Q3. That pathway has really worked really well, and we're looking to try and working with colleagues at TRFT, they've identified patients, newborns coming out of the paediatric wards with the diagnosis of reflux being prescribed Gaviscon and other reflex medication. We're looking at trying to see if we can tie those patients into this pathway. We don't know what the capacity will be, but again, we want to see whether these patients who are coming out on this medication, these infants, do they really have reflux problems, or is it actually a feeding problem? And would they benefit from being part of the pathway? So we're trying to extend that as well. And regarding the diabetes clinics, David, and the Palm tool that we're using, we had a meeting at your practice, and even Lorraine and Jean Toner were impressed with the work that was going on. So that's high recognition there. So I'll stop there and let you ask any questions.
Thanks, Stuart. That's some really good work in there. Any questions for Stuart? Okay, Debbie.
Thanks, Chair. Hi, Stuart. First of all, I'd just like to say well done, really, to the Meds management team, because the figures in this report are really fabulous. If you had to sort of, I don't think you can answer this really because it's such a complex thing, but if you had to give some advice to another CCG, perhaps close by, how have you managed to actually get things like, the item growth down so low and the success that you're obviously seeing? Is there one really, I don't think there can be one thing really, but is there something that you could actually offer that advice to others? Team working, I don't know, whatever.
I think I'd agree with you actually, Debbie, on team working. There's no magic bullet, and the relationships, even working virtually and how we had to have the last 2 years, the relationship that my team have got with practices is really, really strong and really, really good. And I think the working relationships that we have with GPs and GP practices on the whole is really, really good, and with other healthcare professionals. And it is that teamwork approach really, setting realistic targets, recognizing the issues that all sectors of healthcare have, and working to a common goal, and also I think we're part of the finance directorate, which is a bit unusual, but I think we benefit from that because we can see how the money flows in, and again we can have those discussions with finance about sort of, well, we can make an efficiency here, we can make an improvement in patient care here, but it's going to need some investment, or we're going to have to reinvest some savings up front to land that. I think that's probably that kind of matrix working is probably key to our success.
I mean, I was really pleased to sort of see that that towards the end of the report, that two of them, I think it was diabetes and antidepressants. I know that you came along and you worked with our PPG groups, and listened to patients. It's sort of like this co-production, really, isn't it, of the pathway, which it's brilliant to see that sort of working all its way through now, nearly 2 years later.
Absolutely, Debbie, and particularly around diabetes, we keep being told that patients don't engage with services that are offered, but then we don't offer them anything different to what we've ever always offered them, which is like a meeting at the diabetes centre between 9 to 5 Monday to Friday, where you can't park, and most type 2 diabetics are working age and can't always get time off work for these meetings. So taking that patient feedback and redesigning services around patients' needs, I'm a big fan of that.
You and me together.
Thanks. Any other questions for Stuart?
Richard, sorry, I can't get my reaction. I can't put my hand up. For some reason, it's disappeared off the screen. It was just a question, so I'm sorry to jump in, but it was just a question. It was about that, the work around depression, things like that. And I just, Chris was saying earlier about, and I'm really pleased, obviously, to see the increase in grants to the voluntary and community sector providers around mental health, and also the extension of the social prescribing offer to mental health. And one of the things that, you'd said, Chris, and we'd said, was about the need to evaluate it. And one of the things that was always difficult was evaluating the impact it had on any potential reduction in prescription costs. And I just wondered whether that was still difficult to do, or whether that was being built into the evaluation. So it's not necessarily a question to you, Stuart, it's just a link between the two.
It's easy to do. It's quite easy for me to track antidepressant prescribing costs and antidepressant prescribing items. It probably won't help because antidepressants at the moment are really cheap. They're really cheap
Right.
drugs. So it's a cheap intervention, and anything else actually probably costs more. But it's the issue of, don't want to demonize antidepressants, have a place, but it's an issue of targeting them where they're going to be most effective. And because they're cheap, we perhaps prescribe them a little bit too readily, and they're not always the most effective therapy for the reactions that we all get of low mood when an unfortunate life event has occurred to us. I'm really pleased with sort of the rather high things that we've identified, and again that was from patient feedback, which enables patients, other avenues to explore and other places to seek support rather than medication. But medication is actually always going to be the cheapest intervention at the moment.
Yeah, I know. Sort of when we went down for the Health Service Journal Award round, which was around mental health social prescribing, and one of the really powerful things from the video of a patient there was, what's the point of pumping me full of drugs if I've got nothing to live for, nothing to get up for, and everything like that. So it was an incredibly powerful sort of statement that they made.
And again, that's what came out from all the patient engagement work that we did, is that, the antidepressants, well, they don't change anything. You've still got a job, or a job that you don't like, or you're still going to get divorced, or you still can't pay your rent and stuff like that. You just don't care about it so much. And that was consistent with the feedback that we got.
Okay, thanks, Jonathan. Any other questions for Stuart? Anyone else lost? It's in your reactions button, the hands up on Zoom, for anyone else who loses it. Thanks then, Stuart. That's a really good report. We'll see you. Will we get another quarter report in before the end of the CCG or not? I'm not sure.
Certainly we'll do a quarter report. Well, quite where it goes. Well, we'll see. But there will be a quarter 3 report.
Okay.
Okay.
Thanks very much.
Bye, everyone.
Okay, Ruth, corporate assurance report.
Thank you, Chair. So yesterday's audit committee went through the GBAF, the risk register and the issues log in their meeting yesterday. They did question some of the areas, especially those relating to COVID and the transition to the ICB. Members of audit committee discussed the ongoing level 4 incident relating to COVID and the new date for transition to the ICB. The associated due diligence checklist and all the risks that were aligned into these areas. We also discussed the possible recovery plan and staffing issues, and all that just came out of those documents that we presented yesterday. I must apologise for an abbreviation that's been used in the complaints section on page 4. The second line states one complaint relates to a request that test be PSU. PSU stands for pseudonymised, so apologies that that's not been put in full. It does look a bit weird when you do read it. And the only other thing that I wanted to highlight in this report is that to note our excellent position in relation to the completion of this year's Data Security and Protection Toolkit on page 5 of the report. This has to be completed by the 30th of June, and we will continue to report on the progress of that item. Happy to take any questions or comments.
Okay, thanks, Ruth. John, any comments from your
a couple of a couple of things, please, Richard. Firstly, in terms of the GBAF and the risk register, we've now got the head of internal audit opinion stage 2, and that seems to be confirming that our review of the GBAF and the risk register this year at both AQUA operational executive and governing body has been deemed as appropriate, and so the head of internal audit opinion is going in the right direction now. There's a final piece of work for them to do as well. And one of the things we were sort of looking at yesterday was really, the risk ratings in the GBAF have more or less stayed the same all year, and on the risk register there's been a slight deterioration, and that's not surprising, of course, bearing in mind the agenda that we've been working to and the management of COVID, etc. But we did start to explore a little bit about how we might move on from there, and how we might start to see some risk reduction and some improvements in those risk ratings. It was sort of like quite a difficult process still, really, where there's obviously, I mean, go back to what Chris was saying earlier about our relative position on delivery. There's still a big national expectation of improvement, but that's not backed up by or not matched by what can be delivered locally. And I don't just mean in Rotherham, I mean all around the country. So I think that process of improvement is still got some time before we'll start to see improvements. And I guess one of the things, I mean, we will, whether it's at ICS level or at place level or CCG, we will have a 22-23 plans in the not too distant future responding to the national priorities, and that might start to show some evidence of ways in which we're going to improve. So we were just trying to reconcile the planning work with the risk position yesterday, but recognising that there's good reasons why our GBAF and our risk register are showing the position that it's showing.
Okay, thanks, John. Any other comments? Okay, Chris. So you come off mute. I assume you want to make.
No, Chair, I wasn't going to say anything.
Okay. All right. Thanks, Ruth. Just coming on minutes from other meetings then. Integrated Care Partnership. I assume that's what you come off mute for.
Yeah, I was, yeah. I was just going to say I've got nothing specific to flag up in this. Everything should have been through governing body that's relevant. So if anyone's got any questions, I'm happy to take them.
Any questions for Chris? Okay. Janet, Primary Care Committee.
Thanks, Chair. These are the minutes from the November and the January meeting. I'm happy to take. I only just go through briefly some of the items followed through from the November to the January meeting, and I suspect will also follow through into the March meeting as well, around areas like extended access and PCN development, the PCN dashboard, the local enhanced services, both the survey and the revision to the service specification. We also took an update on the dementia pathway at the last meeting too. I'm happy to take any questions if anyone's got them.
Any questions for Janice? Okay. A&E Delivery Board. Anyone going to take that?
I go to A&E Delivery Board.
Okay. Anything you want to raise, David?
Nothing particular. The themes are fairly common through every meeting that we attend. So just with regards to the acute activities, obviously very busy. Things like ambulance handovers cause problems across the system. I think there is some joint working going on between the various partners, which is reflected in the minutes. But the themes are fairly consistent through the meetings, and there is additional work going on to try and address some of the attendances into emergency departments and look for alternatives to avoid as many patients attending, which hopefully should come to fruition in the next few months.
Okay, thanks, David. Any questions for David? Okay, and then last one. Health Executive Group, and it's Chris again.
Same again, Chair. Any questions?
Okay. Doesn't see to be any questions. In which case, I think that brings us to the end of the meeting. I can't think there's any risks raised or any things to escalate that's come up in the meeting. Therefore, we'll move to end the public meeting, and we need to consider the following resolution: that representatives of the press and other members of the public be excluded from the remainder of this meeting due to the confidential nature of the business to be transacted. Publicity would be prejudicial to the public interest. Okay, so we'll bring